Thank you very much for the invitation to come here today. I'm Tudor Toma. I'm one of the consultants in London. I was actually trained, born, raised in Romania, so I spent the last 20 years in London working in chest medicine. And what I'm going to talk to you today, you may think it has maybe nothing immediately to do with interventional bronchoscopy, but in the end, I think towards the end of the day, we will realize that ultrasound and chest ultrasound is actually quite topical and has a lot of information that is useful for the interventional bronchoscopies. So I'm going to tell you basically what we do in our local hospital in Greenwich, Lewisham and Greenwich. And basically the presentation will focus on the role and the developments of chest ultrasound. So the story, let me see if I get this to work. The story and our involvement with chest ultrasound was actually pushed by a report in 2006, 2007 that looked at all the chest drains that were put in England in the hospitals in the NHS, and the report said that no chest drains should be put in patients without an ultrasound. The problem was, who is going to do this ultrasound and how are we going to train the chest doctors to do chest ultrasound? Because at that time, the only possibility was to take the patient to radiology, and the radiology will do a mark on the skin and tell you where to put the drain. So basically, we had to introduce point-of-care ultrasound in the chest department, and the initial indication for that procedure was somebody with an X-ray like this, so somebody who had the consolidation or some opacity on the X-ray, and the ultrasound will clarify if this consolidation is fluid or pneumonia, and if it's fluid, then will mark the spot, will allow you to put the drain, and will tell you where to put the drain. Now, when you start doing chest ultrasounds for this kind of indications, you realize that the ultrasound is giving you additional information which is very useful for clarifying the type of the effusion as well. On the slides, you can see that the ultrasound image shows the consistency of the fluid, and it also shows the type of the lining around the lung, so the pleural structure, the diaphragm. Do we have any deposits on the diaphragm? Do we have any deposits on the pleural surface? And is the lung collapsed, or is the lung consolidated inside of the effusion? So slowly we realized that with the ultrasound you can get very useful diagnostic information, and that process, that information can help you with the diagnosis. Now, how do you train? How do you end up as a chest physician to be able to do chest ultrasound and to be competent? It's not very difficult. There are three components that needs to be learned, and they refer to the technical aspects, to the image acquisition, and to the image interpretation. So very quickly, technical aspects are, again, based on simple understanding of what the machine can do. There are only three main buttons that one would need to know now from a modern ultrasound machine, because most of the other elements are preset by the machine. There are three types of probes, and one would need to know why a particular type of probe is different from another one. We use the convex probe most of the times. The convex one gives you a good image in the depth of the organ, but not very much in terms of definition. The linear probe will give you more information about the details of the image, but will not give you too much penetration. And the cardiac probe has a very small footprint. So for chest ultrasound, we're using mainly the convex, the abdominal probe, and some centers are using the cardiac probe. The linear probe is very good for procedures, mainly for pleural procedures. Image acquisition is actually more important, and people don't really appreciate this at the very beginning, because most of the times in chest medicine, image acquisition is done by a technician and not by the physician. With chest ultrasound, as it is with EBUS, for example, image acquisition is done by the operator, by the person who does the procedure. So a couple of important things to remember about the image acquisition. We need to have the mechanical transmission of the vibration, so we need a good contact, we need enough gel, we need the position of the probe to be in the right place and with the right position, and we need to remember that certain movements will change the beam of the probe, and that will change the section. So we need to do these movements with a purpose rather than try to move the probe and capture some image which can make sense. Scanning areas are variable in terms of location depending on whom you talk to. For example, the intensivists have slightly different scanning areas because they can't position the patient in a sitting position. In respiratory medicine, we can sit the patient up, and therefore the scanning positions are at the base of the chest to see, first of all, if the lung is appearing in a normal, if there is a normal appearance of the lung, then at the back where we can look for the fluid, and then we scan in the second or the third intercostal space for checking if there is air or not for pneumothorax. The scanning needs to be done step by step. It's very easy to get disorientated, so the important step is to see the reference organ, which is liver or the spleen, depending on the side. And then we look for artifacts like curtain sign and pleural sliding. Pleural sliding is actually the real image of the pleura moving and sliding. Image interpretation is probably not as difficult as with other ultrasound techniques. However, we need to understand the role of artifacts in image interpretation in the chest. So there are a number of artifacts, and we'll discuss some of them at the workstation. There are B lines, which are artifacts depending on the consistency of the lung. There are A lines, which are artifacts depending on how much air we have in the lung. And then that artifact can give you also the curtain sign, which is an image going over the liver. And then if you have surgical emphysema, you can have additional E lines as artifacts. This is a normal image of chest ultrasound. You can see the curtain sign very well. You can see the pleural line here, and in addition to radiology, you see this dynamic. So you have dynamic information, which here is pleural sliding. And for example, if you have pleural sliding, you definitely don't have a pneumothorax. So that is very useful. Couple of examples of where does the ultrasound help and where are we going with the interpretation. So this is a patient, for example, with a whiteout lung. In the past, you would do just the X-ray and try to put the drain or not. Ultrasound actually shows the patient has a consolidated mass in this space, and definitely a drain would not be helpful. You can even see the heart through that consolidation. This was a patient with lung cancer in the past, and that is disease progression. However, the ultrasound is helpful not only in patients with pleural effusion. So consolidations, as you've seen, is not necessarily an effusion. So we learned to differentiate different types of consolidations now based on the ultrasound. This is a patient with bilateral pneumonia, and ultrasound will show that the image of the lung is different, so that would be aerated lung, this is consolidated lung. And with Doppler, you can actually confirm that it is consolidation and it is not a solid mass or some fibrotic change. For pneumothorax, I have touched a bit. If you have this kind of sliding, you don't have a pneumothorax. However, if the sliding stops, and there is no more movement as it is here, you have a pneumothorax, so it's very useful. Now, another use is for patients with shortness of breath, and we don't know if it is lung edema, if it is fibrotic chest, or what is going to explain the shortness of breath. Patients, for example, with increased density of the lung will have a change in the pleural line, and that would be in keeping with either lung edema or lung fibrosis. In dynamic, you can see clearly that the line is not a straight line, but it is an interrupted line. And if one would look a little bit more carefully at the costophrenic angles, you'll see there is no fluid there. And the scan is actually confirming this is lung fibrosis. So what I want to say here is if you have changes of the pleural line and you have the absence of the bilateral pleural effusions, your probability is changing towards a fibrotic lung disease. However, if we have the probes, if we have the patients with shortness of breath and we look at the lungs, why not looking at the heart as well? Because cardiac limited ultrasound examination, which is not as difficult to learn as we may think, can give us additional information on the function of the heart. Yeah, so my point here is we need to learn cardiac ultrasound, but we also need to learn to look at lymph nodes, peripheral veins, and the diaphragm, because that will add additional information to the chest physician. This is a patient with DVT, for example, with chest problems, and with an ultrasound of the veins that shows thrombosis and distended veins which would not compress. So what is going to happen? I think everybody will need to add to inspection, palpation, percussion, and auscultation this additional bit, which is insonation, which is exposing the patient to the ultrasound and learning what that information can give us. Basically, my conclusions are that the ultrasound is expanding and it gives us useful information. It's easy to learn and easy to apply, but we need a specific and structured program and something that we will try to demonstrate during these days. I'm here also representing the EABIP, the European Association for Bronchoscopy, and I will encourage you to apply to become a member of this association. So thank you very much.